Okay, so it's 7 o'clock, and I think we can start the proceedings for today. Good evening, everyone, and thank you for joining us here today. We have a very august and accomplished gathering of speakers today, whom we all hope to learn a lot from, and we definitely will learn a lot from. The first two sessions are our masterclass sessions by speakers who need no introduction, but I'll still do the futile task of introducing them before their talks. And after that, we have a collection of practical surgical talks which will follow up. Our first talk scheduled for today is the Medical Retina Masterclass, which will be by none other than Professor Jemmy Chung. When I take her name, she's the world authority on PCV. I don't need to give a better introduction to her. She has a H index more than the life expectancy of an average Indian, and the life expectancy of an average Indian is now 72. I believe it's 82 for Singapore. So she's close to almost reaching the average life expectancy of Singapore. So we all are looking forward to hearing from her. She's a professor with the Duke University and with the Singapore University as well. And it's always a pleasure to hear from ma'am. The first time was when Rajanarayanan sir had invited her for a talk at LVPI on a similar virtual meeting, and that time she had spoken to us about the OCT findings in PCV. And this is like a continuation for me as a fellow with RN sir here again. And we'll just give the floor to ma'am without wasting further time. I'm sure everyone is waiting to hear from her. Good evening, ma'am, and thank you for being here with us.
Good
It's
evening.
3 hours ahead for her in Singapore, so it's almost past 10 for her, and she's still agreed to be here. Thank you so much for that. We're extremely grateful.
It's my great pleasure. Thank you very much for the very kind introduction and for the opportunity for me to meet up and discuss with many of my colleagues in India as well. And many thanks to Roche for the invitation. So let me first try to share my slides. I'll check it's
Your
okay.
slides are visible. Yes, ma'am.
Yes, perfect. Okay, so there will be two parts. The first one will be a few minutes. We'll be sharing the very hot off the press results from the 1 year of the SAWIN study, so concerning new therapeutics. And the second part, as you've mentioned, will be a little bit of a continuation of how we are going to practically manage PCV, especially talking about how much and what can we do with OCT alone, which seems to be the kind of norm for many parts of the world. So let's start. So, I mean, of course, it's a great pleasure to be presenting this data on behalf of all the investigators. It is a team effort. So let's go into it. So SAWIN, this is a phase 3B for multi-center open label. It is a single-arm study designed to evaluate the efficacy, safety, and durability of faricimab in PCV in Asia. In total, there were 135 patients across 9 regions, some sites in India as well, and you can see the distribution here. So on the right is the kind of distribution of the study population, 135 patients. Okay. Okay, so 135 patients. The mean age is 68.6 years, which is quite representative of our Asian neovascular AMD population. And the other quite characteristic distribution is the slight male predominance, which is different from the Western population. In terms of the subdivision within the Asian population, down there you can see that majority being Chinese, but very closely followed were from Korea, Japanese, as well as other Asian populations. As you can see, Indians, Thai, Malays, etc. So the study design, this was adapted and very close to the Tanai and Lucerne, particularly within the first year. So if I walk you through, starting from the left, we started with 4 initial loading monthly injections at weeks 0, 4, 8, and 12. Then we go into the disease activity assessment phase, which we pause and we just watch for any recurrence of disease activity. And this is measured by any of CST increase or BCVA drop or development of new macular hemorrhage. I think you're quite familiar with this. It's similar to Tanai and Lucerne. So basically, if patients do not develop any new disease activity or meet these criteria, they will be dosed next at week 28 and so on and so forth. And they stay on Q16 weeks until the primary endpoint is assessed. And for those who develop or meet the disease activity criteria earlier, then they will get dropped down to either Q12, as in the middle row, or as the most frequently, they can be retreated with Q8, as in the bottom row there. So, and then we continue, they're locked into that frequency. There is no further titration in between. And the primary endpoint is then read out as the change in BCVA from baseline at an average of weeks 40, 44, and 48. Taking 3 time points is to average out the effect of the time from the last injection. So today we will focus on that, and then the study is ongoing in the second year, ending at 108 weeks. So overall, more than 90% of the patients completed treatment through week 48, which is generally very important to note and is a good sign that the treatment seems to be working and patients not dropping off. If you want to be very detailed, you can see at the bottom right, the 9 patients and the various reasons that they dropped out. In terms of baseline ocular characteristics, we've talked about the demographics. In terms of ocular, so one thing that really I want to highlight is the relatively high BCVA at baseline, 64 letters. So if we kind of very quickly get a little bit distracted, is how does that compare with previous trials? In Planet, for example, it was about 58 to 59 letters. In Everest 2, it was about 61 letters. So this is starting off already almost aligned higher than those older trials. In terms of CST, I will just highlight that quite thick retinas, 417 microns. So this is the primary endpoint. We've previously shared the 16-week data already. So with the first 4 loading injections, you can see a very robust and consistent rise in the BCVA with each of those loading. And then remember that from week 16 to week 48, patients are then dosed less frequently than the initial 16 weeks. And nonetheless, we see a continual rise in the BCVA, and we end up with plus 8.9 letters at the primary endpoint assessment. In terms of patients with categorically very good VA of 69 letters or better, which is like driving vision in most countries, again, you can see a rise at the beginning and very well maintained through to week 48 with 77% with this kind of very good vision. The converse is what about with the patients who had very poor vision? So this by and large is very few, less than 5%, which is representative of neovascular AMD trials as well as PCV trials. If anything, there appears to be a numerical reduction from 4.4 to 3.1% of patients with 38 letters or less. Now, these functional outcomes are mirrored by the improvement and control seen in the anatomical results. Here is central subfield thickness. Remember, we started off with 417 micron, again, with the first 4 loading injections decreasing very consistently. And from week 16 onwards, you can see that is, of course, there will be minor fluctuations, but this is very largely maintained through week 48 with an overall reduction of 126 micron. Again, looking categorically at the proportion of patients who had what we call a dry retina, i.e. no SRF or IRF, again, increasing at baseline to week 16 and again maintained by and large to week 48 at 76% without fluid. We also like to see the effect on choroid because a thickened and congested choroid is somehow inherently linked to PCV and various pachychoroid diseases. So here we see that the mean choroidal thickness at baseline was 262. You will note that there is quite a bit of variation with centered deviation of 82 microns, and that was reduced very quickly with the first injection. And that reduced level was well maintained through the rest of the study period. Now, what about polypoidal lesion closure? We always pay a lot of attention to this. Here we represent the ICGA readout on the left-hand side and the ICGA combined with OCT readout on the right-hand side. So left-hand side, based on ICGA alone, we're talking about complete polypoidal lesion regression. And previously at week 16, we were quite excited about the 51% reduction, which appeared very, very fast. And again, what I'm quite impressed about is that between week 16 and week 48, patients are being dosed less. And yet we are seeing a further increase in the proportion of patients with polypoidal lesion closure. So that's very encouraging to me. So now at week 48 or 1 year, roughly that time point, we're looking at 61% of polypoidal lesion closure by ICGA. On the right-hand side is talking about either no polyps or if there is polyps, that these are inactivated, either there is no fluid on the OCT. So combining ICGA and OCT readouts, we're looking at 86%, vast majority of eyes did not have active polypoidal lesions. Now, how do these ICGA closure results compare with other studies? Now, of course, comparison across study should always be taken with a pinch of salt. It could be a difference in various baseline characteristics. The patients are treated using different kind of regimen, let alone the drug. So there are many variables in there. But nonetheless, we can't help but being a bit excited to see that this is by far one of the, if you compare with any monotherapy arms in the previously reported studies, Planet, Everest 2, even the Pulsar with 8 milligrams recently, we have not seen anything that reaches as high as 61%. So this is quite interesting and exciting. And just to put the pictures, give some examples, these are 4 cases from the Sawin study from our SNEC sites. And you can see at the top are the baseline characteristics, ICG and OCT, and at the bottom are the week 48 results. So first 2 cases, case 1 and case 2, are pretty much perfect. You see that vision improved, the ICGA showed closure completely, and the OCT no fluid, and even PED has flattened. Perfect results. Case 4, on the other hand, on the far right, moderate improvement. You can see that it was a lot more aggressive, a lot more blood and SHRM at baseline, and somewhat reduced. The patient has also gained 8 letters, but nonetheless, you can continue to see there is still some residual activity both on the ICG and OCT, but partially improved from baseline. And case 3 is very interesting. There are 2 foci of polypoidal lesions on the baseline ICG, one bang in the middle on the fovea, and another smaller one further inferiorly, if you can see that. Now, after treatment, you can see on OCT, this has improved a lot. There is no SRF, no IRF. There's still a bit of PED. And in fact, on the ICGA, you can see that the fovea focus of polypoidal lesion has completely closed, whereas somehow the inferior part of the lesion is still there. So this is partial closure as well. So overall, even out of your 4 cases, it reflects very much the 61% closure rate, which is reported in the overall population. So coming into now, after week 48, patients are then going into the second year. The second year design is interesting because it's some modification from the original Tenaya Lucerne, in which it gives a more flexible treat and extend regimen, allowing us to treat from between Q8 to Q20, so reflecting a more kind of clinical and practical paradigm. So therefore, at this time point, at week 48, patients could be assigned to as long as Q20, not just Q16. So here we see that at the end of the week 48 assessment, more than 50% of patients were indeed assigned to Q20 weeks. On the right-hand side of the pie, it is exactly 53.2%, which again is another indicator that many cases are deemed to be very well controlled and stable by their treating investigator, and also speaks to the durability of the drug. So how about safety profile? I'll leave you to read this for a short while, but I would just say overall, there is no new safety signal. Now, if we look at intraocular inflammation, there are a few cases of iridocyclosis iritis. They are mild cases and they resolve with a little bit of drop. And that occurs with any biologics that we put into the eyes. We know we want to specifically look at one or two other things. Retinal occlusive vasculitis. Okay, so there was indeed one case that was reported by the investigator. So all the pictures were then sent to an independent reading center. So, but somehow that the reading center actually came back and said that they did not confirm any sign of occlusive vasculitis. So sometimes maybe there may be some false features that was noted during the examination, so that was not confirmed. The other issue I probably want to particularly look at in PCV population is the rate of retinal RPE tear, basically. And you can see that 2 lines below, and there was really just one patient out of 135. So all in all, very favorable safety profile. So with that, I'll just conclude this first part specifically regarding faricimab. We've seen overall very consistent and very encouraging results. First of all, in terms of BCVA gain, remember I stressed that patients started off with 64 letters, very high vision, and on average went on to gain another 8.9 letters. So on average, the ending vision in this trial was 72 letters. And we know that there can be a ceiling effect. So the higher they start off with, the harder it is for them to gain. So overall, this BCVA gain, I would say, is actually very impressive. And this is accompanied and consistent with good anatomical control, both in terms of CST reduction, as well as in PCV, a very high proportion compared to previous studies of polypoidal regression based on ICG. And in terms of durability, allowed over 50% of patients to be assigned to Q20 weeks. So this is really kind of the new frontier. We've been extending patient up to Q12 with traditional anti-VEGF. More recently, we've been trying some patients up to Q16, but now with newer and more durable agents, we are looking at Q20 weeks. Of course, remember that is not for every patient. Not 100% of patients can all go on to Q20 weeks. So here we're looking at 50%, and we'll look at the year 2 data to see how they fare in the second year. And finally, just to complete the picture, of course, we want the drug to be safe, and the safety profile was also in keeping with very good safety profile as well. So with that, I would just pause with the first section, and of course, thank all the investigators and participants of the SAWIN study. And you can see where the Indian study sites are on this slide. Now, I've been presenting this data to a couple of other areas, including, for example, in Hong Kong, in Malaysia. And what it was very interesting was I was asking the colleagues there, which part of this data do you find most impressive? And half of me thought it would be the polypoidal lesion closure, but somewhat surprisingly, particularly the colleagues in Hong Kong feel that it is the OCT control. So I asked them, why is that the case? And the answer was actually they don't routinely perform ICGA, particularly to monitor the cases after treatment. If the OCT is doing well, they don't actually do ICG anymore. So for that reason, I think it's still relevant to come back to ask this question: is OCT sufficient already for both identifying and monitoring PCV, and try to put some of that learning into the study trial? So we know that PCV has distinct feature. Before talking about imaging, we know that there are some clinical features which may help us discern PCV cases from typical neovascular AMD already. But ICGA has been traditionally considered the gold standard. And of course, we learn about many features on ICGA, and I won't really go into that, but it's customary to show a pulsating polypoidal lesion, and there it is. And just to remember that on the ICGA, there are 2 portions of the lesion, the polypoidal lesion as well as the branching neovascular network, which is very clear on this nice example. This is old, and I'll just go through it very quickly. I want to look at the pitfalls of this study. And others have actually demonstrated that various combinations of OCT-based features can already identify PCV from and differentiate them from neovascular AMD. Just very quickly go through. So the three major criteria are shown in these three examples here: a sub-RP ring-like lesion, an en-face complex or geographic RP elevation, as well as the sharp or narrow peak PCV, PED, and that gives us AUC of 0.9. Here again, just showing you the three examples. And more recently, we've had the opportunity to apply these data to a neovascular AMD dataset from the West, and namely the Tenayan Lucerne trial dataset. So just walk you through that. In the Tenayan Lucerne, we remember it's a very large clinical trial of neovascular AMD in Europeans in the US, with about 10 to 15% only from Asian sites. So it's predominantly a white population patient. Over 1,300 patients were randomized. 1,300 had gradable OCT and color photos. There was a subset of 274 who also had ICG, but the majority of them, 1,044, did not have ICG. So what did we do? We applied that data set, first of all, to those 274 eyes that had both ICG and also OCT. And we've talked about the three major criteria in the APOIS study, but we don't have en-face. So in addition to having the ring sign and the sharp peaked PED, we also we thought we'd entertain the notch PED and the double layer sign to see if that adds to it. So the examples of these four signs are shown on the left, and you probably will be quite familiar with them. Here are the results, and I will just highlight here. So overall, on the far right, you can see AUC generally was excellent, 0.93, 0.94. And if you just go for the two major criteria without adding the extra DLS or the extra NPED, just the two major criteria, we already achieved 0.94 AUC, which really validates the APOIS finding. And I just want to highlight that on the left-hand side, these two examples are really the cases from the Tenayan and Lucerne trial. And if you didn't go through this exercise, they have been just looked at as neovascular AMD, and they're pretty obvious PCV cases here. Now, having done this first part, we can be now quite confident about the good performance of using these two features. We then now apply this to the rest of the 1,044 eyes with only OCT and no ICG. So the overall readout in this population was 6.6. Okay. So, and again, on the right-hand side, you can see the various types of OCT that was submitted in the Tenayan Lucerne trial. And they, again, I would say, are very, very characteristic. I hope that by now you take one look, even if it was a patient from the US, for example, not suspecting PCV, but these are very clear cases of PCV. So now that we've done this exercise, we'll be able to go back to collate this subclassification with the treatment outcome as well as the durability in the Tenayan Lucerne, and that will really complement the 135 patients that we have in the SALWIN study for us to understand the performance of faricimab on PCV. So back to our initial question, can we only use OCT to identify PCV? I would say yes. In the majority, of course, it's not foolproof. Nothing is foolproof, but 9 out of 10 is pretty good to me. Having said that, there are a couple of pitfalls I've seen. How could it happen? The main thing is overcalling what is a sharp and narrow peaked PED. So if you look at the first example here, these are two dome-shaped PED. They're pretty round to me. Some people use a vertical upshoot of a 70-degree. You could say perhaps that is vertical enough for the left-hand side PED, but overall the height versus the width, it is quite a square-shaped, a dome-shaped elevation to me, and it's not a narrow. So I would highlight the narrow and the sharpness of the elevation. So overcalling, to me, this is not a PCV, and it is not a narrow peaked PED. So, but if someone decides to overcall these, then of course the performance of that criteria will not be as good as previously reported. Secondly, there could be some, it's not foolproof because it may miss out on small baby polyps. So this is illustrated in the middle example here. Of course, there is an DLS, double layer sign, and on the two tips, there are little higher elevation. It would be very hard to know if these are small polypoidal lesion or not. So this is the kind of area where the criteria do not perform so well. And finally, of course, if there is massive hemorrhage, you have huge suspicion that this is PCV, but you can hardly see where the RP is. Like the bottom example, all that subretinal hyperreflective material is blood, and only at the bottom right you can see a little notch of what we believe is a PED somewhere in the head. So it's very hard to expect the OCT criteria to perform in that kind of cases. So while it is quite well known, we've talked about these APOIS criteria many times, I just want to highlight there could be these kind of pitfalls when we apply them. I said not everything is foolproof. Okay, so the OCT criteria is not foolproof. ICGA criteria also not foolproof. So multimodality is useful. These are very classic cases of pseudo polyps or hotspots on ICG, which turns out to be not polypoidal. The first one is a RAP, the second one is a macro. The third one is in this case, secondary telangiectatic area, secondary to an RVO. But if it is not a diabetic patient, not an RVO patient, now we recognize the PVEC or large retinal macro aneurysm. And on the right-hand side, if you just have a very quick look at the thumbnail, there is a hotspot, but this is actually an area of atrophy and window defect. So ICGA, although the gold standard, also is not always foolproof. How about monitoring? So we've talked about diagnosis performs very well. What about monitoring treatment response with OCT? I think it is extremely useful. As I mentioned, Hong Kong colleagues shared that that is really the go-to tool that they use. So let's look at and pause for a moment, and I'm happy to discuss later on as well. Yes, we can use that, but let's talk about what are the features we look at on the OCT. So two ways to answer this question. First is that what can we see? And out of the things that we can see, which of them are important? And are there something that we can see but may not be functionally relevant? On the other hand, are there things that are important we would like to know, such as polypoidal lesion closure or not, but may not be so visible on OCT? So let's have a look at some of these. What can we see with OCT following treatment? What does OCT do well? These are some of the points that I came to my mind. Of course, resolution of SRF and IRF. Of course, thickness. So we've reported those as a standard anatomical outcome in clinical trials, and we've heard about them. But in PCV, in addition to fluid, we also want to pay attention to a few things. Resolution of subretinal hyperreflective material, which may be blood. Reduction or resolution of the PED often is not completely gone. Like in the left-hand case, there is some reduction of that PED, some flattening, nonetheless not gone. Whereas on the right-hand side, there is resolution of SRF and IRF, but the PEDs stay the same. Then, of course, we prefer to see the treatment response in the left-hand case compared to the right-hand case. What if the contour doesn't change? What about the content of the PED? If there is a change in the reflectivity of the PED content, we shall see it's been shown that that is also useful to note, which informs us on the perfusion status of the polypoidal lesion. And finally, we can also see a reduction in choroidal thickness, as already reported to you from the study just now. Now, we look at a combination of these features, and we can also use that, and previously we've reported that, for assessing suboptimal response to anti-VEGF. And we found that if there is persistence of a sharp peak PED, sub-RP ring, and orange nodule, these features suggested that when you have an eye that still has fluid despite your loading dose, highly likely to be a PCV cases. So such as these two examples, both have some persistent fluid, whereas the top case is a PCV and the bottom case is a type 1. If that happens, a few strategies you can employ, such as consider switching the anti-VEGF, shortening the anti-VEGF interval, or combining with an occlusive therapy modality. Next, we want to talk about polypoidal lesion closure. So as mentioned earlier on, Selwyn's shown very nicely 61% ICGA closure. But what if we don't do ICGA? We've got an eye that has dried up in terms of SRF and IRF, but how do we guesstimate whether the polypoidal lesion itself has closed? And I just want to highlight two studies, one from ourselves and one from the Thailand group later on, which show very similar findings. So here we found three features. First is the densely hyperreflective PED content. So again, we show you the M sign. These two are narrow peaked or sharp peaked PED. You can roughly see a ring there at baseline, and after treatment at the second row, you can see a flattening of that PED. It's not completely gone. There is no SRF anymore, but within that PED, the content has become completely hyperreflective, and we don't see any serous component. We don't see any ring inside it. So a densely hyperreflective PED content, together with absence of SRF, absence of ring, as illustrated in this case, highly consistent with ICGA closure. Similarly, Vorapon's group also showed that they coined it a bun sign. Either, of course, no PED, but to be honest, is rare. Often there is still some remnants of the PED. So they said that if there's presence of PED with internal homogeneous hyperreflectivity, so very similar to what we've described in the previous paper, they call this the bun sign. So that again, I think just two groups coming together, finding this sign is highly useful for us to guesstimate that an eye has closed the polyp. And the reverse is true. This is the case. On the left is before, and on the right it's after. And we know that sometimes new polypoidal lesions can develop over time. And when you see that there is a ring sign here on the right-hand side, you should suspect a new polypoidal lesion. And then now we've talked about how OCT may be good. Let's also look at the flip side and be complete with our analysis. What OCT may not be the best for visualizing? Let's highlight these and talk about what other aids or imaging tools or modalities may come into help. First of all, blood. We know that blood generally appears as subretinal hyperreflective material. This is non-specific. A number of other features or lesion components, such as type 2 neovascularization, fibrosis, exudative material, can all look the same on OCT. And sometimes if the blood is thin, it may not even see it on the OCT. But how about polypoidal lesion status, especially when there is no fluid? So here is the same eye over time, treated and followed up. And you can see that it's basically at baseline, month 3 and month 12. You can see resolution of the SRF, flattening of the PED initially, and over time the PED became bigger again, and you can see the ring reappearing in one of those two humps. So here the OCT makes us guess that maybe the polypoidal lesion initially responded but slowly came back. And indeed, on the ICG shows that. But what we notice is that we don't seem to be able to comment on the branching neovascular network on the OCT at all. And in fact, on the corresponding ICGA, it seems to have completely gone. But look at the OCT angiography on the right-hand side. It gives us so much more information. The BNN has always been there, and the branching has continued to change. It's actually, the branching has become much less complex over time, and suggesting it to be maturing. So here, OCT is not great for assessing the branching neovascular network, I'd say. Here is another example. Resolution of SRF, the PED looks the same. What about the BNN? It was staying exactly the same throughout. and the OCTA shows you very clearly. Here again, completely close on ICGA and also on OCT and geography. You can see that even between month 3 and month 12 on OCT and on ICG, it looks exactly the same. But on OCT and geography, we realize that the branching of the BNN is increasing with time. Now, whether it is going to one day become exudative and active again, we still don't know. But nonetheless, it just shows us another facet of the lesion that we appreciate better on the OCT and geography compared to OCT and ICGA. But right now, we don't fully understand the impact of it. What about fibrosis and other features? The health of the other outer retinal microstructure, the RPE, the photoreceptor, etc. These are the OCT. Very hard to tease out. Again, the subretinal hyperreflective material. Somewhere in there are bits of the remnant RPE, but perhaps autofluorescence will give us better clue about the status of the RPE, and perhaps more advanced tools such as assessing the EZ with AI or even AO, adaptive optics, will be really necessary for us to understand what's happening to the photoreceptors themselves. So with that, I'd like to summarize the imaging part. So non-invasive OCT is a highly accurate alternative for diagnosing PCV. We can accept that, I think, and it's also effective in monitoring treatment response in general, but nonetheless, there are some areas which is not so good, and maybe newer imaging modalities can complement it. So with that, I'd like to finish my talks, and I'm very happy to discuss and answer questions.
Thank you, Professor Chung, for that wonderful talk. The imaging you showed was really nice. And I'd like to open up this session for questions. RN sir, Rohan sir, and Bhavik sir, Dr. Anubhav, Dr. Kartikeya, Atul sir.
No, great talk, Jimmy. It's always a pleasure to hear you and your insights on that. So, as you rightly pointed out, the baseline vision in your particular subset of patients, Alvin, was pretty high compared to the others. Typical AMD and PCV study, 68 baseline, which is closer to the ceiling, as you mentioned. So, obviously, the patient did not have adequate opportunity to show further improvement. So if they had, let's say, around 60 letters, would they have gained 12 letters or maybe more? But the polyp regression of 50% and 61% at 16 and 48 weeks. So what it shows is that most of the regression happens very early, and there's not much of a change beyond the first 4 months or so. Would you be able to compare? I mean, it's not a direct comparison, but with brolucizumab, where there have been some studies and reports about the regression rates being higher, but in my experience, the regression took much longer in brolucizumab compared to what you are showing here. Do you have any thoughts on that?
Well, I think, as you said, it's very, very difficult to compare across studies. Probably brolucizumab, and even, for example, aflibercept. If we go for the clinical trial, we remember Planet was reporting below 40%, around 30 something to up to about 40%. But then in the real world, many Japanese group, they tend to report higher proportion. So I think part of it is how strict one reads the ICGA. We know that treated ICGA is a bit messy. Sometimes the dilated choroidal vessels, it's very hard to know if it is completely closed or not. And also the patient characteristics. I tend to have a feeling that if you treat them early, then they tend to respond more readily. For the more chronic cases, maybe they're harder to respond. So, but back to the time point is that, as you mentioned, the most obvious closure happened within the first 4 injection, and it happened monthly, which is what we expect. So at first, when I saw the week 16 results, I was pleased, but I'm always a skeptic. I said, well, let's wait first. Let's not be too excited because what if it drops? I mean, at best, we would say, oh, if it's maintained, right? Because from week 16 to week 48, many patients are getting only two more injections, right? If they're on the Q16 weeks. If the two can maintain it already, I would be quite happy if there is no reopening. So somehow it's quite interesting to actually see that some patients close later as well, and despite having fewer injection. So, I mean, there are all sorts of theory. Of course, Roche is very excited to try to link it to vascular stabilization, which I suppose is consistent with the finding. And that's why I bring in the OCT angiography. It would be very interesting if we can eventually analyze the OCT angiography and put together some clear evidence of vascular stabilization, which right now is more of a concept more to do with what happens in the dish to me than clinically. We're still not very sure what we should be looking at in the imaging to prove that there is vascular stability. But actually, I'm interested to hear about all of you about how much importance do you put on the polypoidal lesion regression, or you think once we've stabilized, fluid is gone, then whether the polyp is closed or not, how important do you think that additional piece is?
That's a very important question, Jimmy. In fact, I was about to talk about that because I would say right after Planet, most of the world, I mean, even otherwise, they did not have access to ICG. Most of the centers, private as well as academic centers, at least in India, don't use ICG. But right after Planet, when we started to see inactivity, that's what people started hanging on to. But now with the combination of the OCD as well as OCT angiography, that probably is a more useful tool for the practitioners in general compared to ICG. I would say less than 10% of practices have ICG capability. So I think we to make it real world applicable, we should probably look at more about OCT angiography.
Yeah, I agree with you. Yeah.
That's a very valid point by RN sir. In the city I practice, there's only one retina practice which has a ICG. I myself am in a practice which doesn't have an ICG, or we don't use ICG. So the OCT findings are very important for us. And just one more thought I wanted to add on the point of vascular stabilization. Do you think the dissociation constant of faricimab plays a role? If you compare the dissociation constant of faricimab, aflibercept, and brolucizumab, faricimab has a very high dissociation constant compared to the other two, which means that its VEGF binding capacity or speed is much lower compared to brolucizumab or aflibercept. And that low dissociation constant allows it to say act like, you compare a sponge, one which rapidly absorbs water and one which slowly absorbs water. So the one which slowly absorbs water will still have the ability to absorb new water which is coming in, but the one which rapidly absorbs gets moist and wet and completes all its binding capacity. So does that slower dissociation or slower binding to VEGF in chronic diseases allow it to keep binding to more VEGF as it's released, and that causes regression? Do you think that could have a that could be a reason?
I think what you brought up is very interesting, and I think as a clinician, there appears to be a system, right? We talk about the various properties, the binding affinity, the dissociation constant, the half-life, all these, and then another piece we always don't fully understand is how well it penetrates the RPE. And initially, it was linked to the molecular size, but now we know that even big molecules can even penetrate deeper. So I think each of these is important, but as a whole, they all interact with each other. So it's a system. But of course, what you've described, if it is high on one aspect, it does help. Yeah.
Any other questions? We are at
Yeah,
7:45.
Dr. Chawla has one comment, I think.
yeah, very nice talk, Dr. Jamie. Just a comment regarding the OCT features. All of us have definitely started using those. But one point I have found many times is that the typical ring that you describe, say sometimes may be difficult to pick up. So rather than a typical ring, we just say that if it is a heterogeneous tall peaked PED, that itself might be sufficient. I would like your comment on that. And the second thing about activity, definitely absence of, even after absence of SRF on the OCT, I would say that if the height of the PED has started increasing or we have newer PEDs developing, we definitely take that also sign of activity and re-inject.
I
Your comment.
absolutely agree with you on both points. Yeah. I mean, with the ring, I suppose it also depends a little bit on the individual OCT instrument and the number of averaging. We generally use 9 averaging on the Heidelberg, and that works better than on the Cirrus for us for looking at the ring. But yeah, I mean, just now I showed that if we have the basically hyperreflective content, it's closed. So if you don't have that, exactly what you said, if it is heterogeneous, then it is still perfused. And definitely, what you highlighted, I completely agree, and very important is it's very good to say, okay, if you see the good things, it's fine, it's fine, it's fine. But I never emphasize enough is when you start to see it going the other way. It is when you've got a flattish PD and one day the PD starts elevating again, you start to see the serous component under the PD. Traditional treat and extend don't consider sub-RP fluid, but really once the PD content becomes serious, it means something is leaking under the RPE. So I fully agree with you when I see that a couple of things. Number one, I look at the eye to see if I see a red nodule, any hemorrhage. And number two, I will stop the extension. I may maintain if it is mild, but for sure, I would not continue to extend when I see those features.
Thank you.
Yeah, I just want to extend Arjun's point that based on Dr. Chung's presentation and the different cases, case 3, where you had a macular polyp as well as an extramacular polyp, and the macular polyp regressed, the extramacular one was still persisting. The VEGF response of extramacular polypoidal lesions probably is different from the macular lesion. We also know that the extramacular lesions are not that associated with the branching neovascular network compared to the macular ones, and also the extramacular ones can rupture and bleed much more, cause massive subretinal hemorrhage, which may not respond to anti-VEGF. So I think that's probably something which is a pointer over there, that extramacular versus macular polyps response to anti-VEGF could be different.
Yeah, thanks. Isn't that amazing? Same eye, exposed to the same content or chemicals bathing it all around, but then different responses in the different parts. Yeah. I think
Good
there's
one.
also on the chat very quickly before I end, any thoughts on pachychoroid pathology? So there was the one slide summarizing choroidal thinning, which is encouraging, but it is not something new. We've seen with various agents previously, which thins the choroid. And again, Rajan has mentioned brolucizumab, which out there is believed to be the most choroidal thinning potent agent. I think if there are a lot of the pachychoroid component, very thick choroid, congested background, CSR background, thinning the choroid appears to be helpful in individual cases. But nonetheless, when we looked at the Everest 2 study data and look at the various biomarkers which help predict either vision or functional outcome, choroidal thickness in the Everest 2 trial itself did not come out. So I think my personal belief is important in a subgroup of case, but may not be in everyone. And again, go back to look at the mean choroidal thickness in this population. We always say PCV have thick choroid. We always see that it's only 200 something, 262 was the mean, but there is a huge variation of SD of 82. So probably it's only particularly useful in that group, subgroup that had the more thick and congested choroid. Thank you.
Yeah, excellent talk, Dr. Jamie, for providing us
We'll
details.
just take this last question, Dr.
Yeah.
Anubhav, and then move on to RN sir's talk for lack of time. I have a few questions as well, and I'm sure everyone wants to just bombard Professor Chung. But thank you so much for that talk. And RN sir, you can just share your screen while Dr. Anubhav goes ahead with his question.
Yeah, so my question is to Dr. Jamie and Dr. Raja also. So sometimes we do stuck up in a situation where there is non-complete regression of polyp and there is polyp inactivation. So I would like to ask that whether there are some cues or pointers on OCTA or OCT where we don't have ICG angiography, so that we can assess the risk of reactivation in such a scenario where there is improvement, there is incomplete regression, and what are some pointers or cues from OCT or OCTA so that the risk of reactivation can be quantified, or we can assess the risk of reactivation among different clinical scenarios so that we can plan the patient follow-up visits accordingly. So yes,
Raja, you want to do?
Yeah, I mean, it's a good question. I think Dr. Chung alluded to some of that. When obviously on OCT is the fluid. If there's fluid coming back, that shows recurrence. But if you start seeing PEDs coming back, or on Octa, the pattern of the blood vessels changes. Let's say from a dead tree pattern of large trunks and fewer branches to now more of smaller branches and many more branches, like a fern petal kind of appearance. Those are pointers that these patients may start exuding again. And also, Dr. Chung, if you recollect, she showed the ICGs of those patients, where she showed the long follow-up of those patients, where the BVN or the BNN changed on Octa, but the ICG did not show much of a change. But even on ICG in the late phases, if it's showing a late geographic hyperfluorescence like a plaque, those have also been deemed to probably predict future exudation in those patients. But obviously, with ICG not being available for most of us, the obvious thing is the fluid. But if you see a change in the pattern of those blood vessels from large trunks of dead tree to smaller branches, I think that's what would predict it. But Dr. Chung can probably, she's a better expert. She'll probably tell us more.
No, you've highlighted all the salient points. But OCTA generally is like much harder and a lot of variability. So I think just keep it simple is actually, as Dr. Chawla has mentioned earlier, the PED.
thank you so
Thank
much.
you.
Thank you so much, Professor Chung. It was an absolute honor and a privilege to have you here with us. I'm going to take the liberty to mail my other two questions to you and bother you a little more with this. And good night, and thank you so much for joining us. Our
Thank you very
next,
much.
thank you, ma'am.
Great to
Bye-bye.
see you all. Thank you.
Thank you.
Our next speaker and the second masterclass for today is Dr. Raja Narayanan. He doesn't need any introduction. I'll probably need 30 minutes myself to introduce him and list his achievements. We know him as the secretary of VRSI. We know him as the head of ABRI, LVPI Retina Services, and now he's the head of the FlowMy Institute. Thank you so much for being here, sir. The floor is yours.
Thanks, Arjun, and everyone for the invitation. It's a pleasure to be speaking to you all. My talk is on silicon oil PFCL layered sandwich, and it's important to look at the keyword here. The keyword is complex retinal detachment. So it's about not as a routine practice, but it's in eyes which have very advanced PVR, where you have a very high chance of a recurrent retinal detachment. And here I would like to acknowledge my co-author Khushbu, who was a fellow earlier, is now a faculty at LV Prasad Institute. So complex retinal detachments can have very variable success rates when you do surgery for them, mainly vitrectomies. There can be either pre-existing PVR, or they can have other risk factors such as a choroidal detachment, post-trauma, subretinal hemorrhage, hyphema, or vitreous hemorrhage. These are patients where you can have a very high risk of recurrent retinal detachment, and the primary success rate could be much lower than 50% as well. So these are the kind of situations where we have to start thinking that if there is a more than the usual 10% recurrent rate, so normal retinal detachment, we say this, the attachment rate is close to 90%, which means the redetachment happens only about 10% or so. But if you have a situation where the recurrence chance is 20, 30, or 40, 50%, or you have sometimes you feel as if while you are just closing the eye, you think this eye is going to redetach. I don't think this will stay attached. There are such challenging cases as well. High myopia, third surgery, fourth surgery. Those are the cases where you really want something more than just an AK-47 kind of bullet. There are some newer advances, including methotrexate, which has had a resurgence recently. It's not a recently evaluated drug, but it's in vogue right now. A lot of publications coming up, starting from Dean Elliott at Mass Eye and Ear. But every repeat surgery that we do, you have one redetachment in that eye, you go in again, there is a higher chance of recurrence than the first surgery. If the first surgery itself had a recurrence, the second and the third surgeries have an even higher chance of recurrence. And what we end up doing in many of these patients is limited retinectomy or a 360-degree retinectomy. I'm not going into how to do a retinectomy, what features should we look out for, when to do, but whenever there is a retinal contraction, inherent shortening of the retina, and you have to do a retinectomy, these are very high risk cases for a recurrent retinal detachment. And I was talking about methotrexate. Numerous presentations and publications have come up, but the drawback is repeated injections. Initially it was started every weekly, then now it's every 2 weeks in an oil filled eye. It's not easy to keep injecting in a patient with retinal detachment, inflamed eye, silicone oil for about 8 weeks or 12 weeks. And then the success rate is about anywhere from 65 to 80% if you do these multiple injections. In fact, there is a study reported by Tamer Mahmood's group recently that uh, those patients who had very advanced PVR, they injected methotrexate at the end of the surgery along with the silicone oil, then kept on injecting methotrexate every 2 weeks, and even after silicone oil removal, they kept on injecting methotrexate for another 6 injections. So imagine the number of injections that you need to give even after silicone oil removal to achieve a reasonably good success rate of about 75% in these eyes. Now, certainly anything better than that we should be exploring. And this is a young boy who had come to me when I was at LV Prasad Institute. You can see it's barely visible, but a closed funnel detachment in both eyes. One eye was inoperable or left alone because of no light perception. The other eye, we said we will take it up. And these are the kind of eyes where the optic nerve is not visible, it's just bare RP and choroid, it's all funnel. And the first thing which strikes is while I can do a heroic surgery and open up the funnel, it's a bimanual surgery with the chandelier. We open up, remove all the membranes above and underneath. So the first thing is under the retina because only the undersurface of retina is visible at this time. But once you open up the funnel like a shoe flower, you open it up, you need to be very meticulous in removing all the membranes, subretinal, epiretinal, use forceps, ILM forceps, stain. You can use a finesse loop or a diamond dusted scraper to clean up the entire PVR. But let us be honest, when even if we are able to open this funnel and kind of reattach the retina, right when we are about to close this kind of an eye after doing laser, we always have not just a doubt, we always have a big worry that this eye is going to probably redetach. So with this in mind, I started doing a layered PFCL silicone oil sandwich way back in 2013. It was initially reported by Stanley Chang as a PFCL C3F8 or SF6 gas combination, not as a silicone oil, but PFCL gas combination much earlier. And although PFCL was initially thought to have very high toxicity, we always used to remove the PFCL, but Stanley Chang himself started doing these kind of sandwich techniques, which where he left the PFCL in the eye for a month or so. And then we also started doing full PFCLs. We have now heard a lot of presentations and even publications where you leave the PFCL in the eye for a week or 10 days for very complex detachments, including GRTs, and then go in after 10 days or so and fill it up with gas or oil after removing the PFCL. But what I started doing in very complex cases is leaving the PFCL silicone oil for a time. I initially started off with leaving them for a month, and then as I gained experience that there's no sign of toxicity, then I started extending the duration, and then I also have been actually leaving the eye completely, the PFCL sandwich for many years now, in cases where it's required. So this was a retrospective study. While the study duration for this series is 2016 to last year or so, but I started doing in 2013, but we didn't have those patients' full records because we did not have electronic medical records at that time. The patients, we had 34 eyes, mainly males, and the vision was hand motions. Mean age was 42, and we had all kinds of situations where the prime it was very bad detachment like post trauma or recurrent detachments, either the second or third time with very advanced PVR. And some of them I did kind of do a two-step surgery, fill it up with PFCL completely, and then remove part of the PFCL and fill the rest of it with silicone oil. But what was interesting when I look back at my data is that we had a success rate of about 90%, which was very unusual for these kind of very advanced detachments. So otherwise, these are cases where you would feel that the success rate would probably be around 50 or 60% at the most, or if you keep giving intravitreal methotrexate for many months every other week, it may come up to 70 to 80%. But again, with more experience later on in my experience, I started leaving these patients with the sandwich. There's hypotony, and I know that if I remove the oil, there is still a chance of recurrence. What about visual acuity? About 20% of patients achieved more than 2400 vision, but the mean visual acuity was about 3-line change to about 2800 vision. This is an example where I where I mentioned about that young boy, um, complete GRT, and you can see the so meticulous membrane removal is still a requirement. PFCL cannot counteract significant PVR forces. So if you leave retinal contraction, if you leave epiretinal or subretinal membranes, the retina is going to redetach even under PFCL. So it's not a substitute for a good surgery, a meticulous dissection of PVR. But in this boy, I left the eye with PFCL. He had a GRT 360. I left the eye with PFCL, and then what happened after a few days? The superior edge of the GRT had slipped. As you can see here, it's all folded like a curtain, and then you see this bare RPE. the original laser mark. So now I had to go in and pull this back up. Now, we all know that heavy silicon oil, Denziron, is another option for these tough cases, but it's been reported that if you have a heavy density liquid, the superior retina redetaches. If you have a lower density liquid, the inferior retina detaches. So we know silicon oil, the inferior retina starts detaching because silicon oil does not provide good tamponade to the inferior retina. And the reverse is true for PFCL or any heavy liquid. It gives good tamponade to the inferior retina, but the superior retina does not have a good tamponade with heavy liquids. So the PFCL silicon oil sandwich is a compromise where you use both heavy and light tamponade, supports both inferior and superior retina. There are challenges to retaining this long term, but I'll come to it. So I had to do a repeat surgery, remove the membranes from the superior retina, unfold the edges, and then in this case I had to do the sandwich. Like I had to leave PFCL as well as silicone oil, and this is after the surgery. This silicone oil, you see the reflection of the optic nerve on the lower meniscus of the PFCL. And this is another patient where the patient was a high myo. This was the third kind of surgery. She was referred to me post two recurrences, and then I had to do a meticulous dissection. There were multiple inferior retinal breaks, thin atrophic retina, third surgery for her, and I wasn't able to relieve the contraction, intrinsic contraction of the retina completely. Here's the finesse loop. So as I said, you must do a complete dissection, meticulous removal of the membrane. So ultimately, this was also, and this was done here at Flama Institute, a very bad closed funnel detachment, as you can see here, thick bands, the disc was not visible, and finally I had to open up the funnel um, and then do a retinectomy as well in this 360. I'll just fast forward this and then lasered the retinectomy and then we had to do this. So these are the different patients where you have a PSL silicone oil sandwich. Now the question comes, one is of toxicity and the other is how much PFCL to leave in the eye. Typically, it depends on the location of the retinectomy. If the retinectomy is posterior, you have to put more PFCL. If the retinectomy is anterior, you can have less PFO inside. In terms of toxicity, it's a difficult question to address. Obviously, inflammation and vasculitis was not seen in these patients. That's easy to observe. People have suggested ERG, but I would say ERG is not a useful tool in silicon oil filled eyes. Forget about PFCL. Even if you inject silicon oil, it just dampens the signals from the retina. So ERG is not a good test for measuring toxicity in these patients. But so far, we didn't see any inflammation, corneal toxicity, or retinal vasculitis in these patients. So in conclusion, splash is a good option in some of these patients. Now, this is not for all patients or all complex patients. You have to choose your patients carefully, but it's a good tool for us. So thank you very much for the kind attention.
Thank you so much, Aaron sir, for showing us all those challenging cases. Dr. Aaron has to strictly leave at 8:15, so we have 7 minutes to bombard him with our questions. I'd like to open up the session for questions from the panel.
Very nice and very tough cases, Dr. Raja. So I've been routinely leaving PFCL now for such tough cases. I have not done a sandwich. So just a few queries. In my mind, I always had this idea that when you mix fluids of different physical properties, the chances of emulsification all become higher. Did you find that, or do you think that despite mixing, it doesn't make that much of a difference and the oil still stays okay for a long time? Number one. And number two, which you partially answered, how much is the percentage of PFCL and oil mix in these cases?
Yeah, those are very good questions, important ones. So the emulsification is I haven't seen, because in all my patients I have been using the 5000 centistokes oil. Maybe it's of a purer quality, I don't know. But PFCL and silicone oil don't emulsify, but there is another phenomenon which happens. So when you keep PFCL and silicone oil, especially PFO, not decalin, but perfluorooctane, and that's a challenge. I haven't used decalin as such with silicone oil, but perfluorooctane with silicone oil, if you leave in the eye, quite often the PFCL becomes very thick and viscous. So if you go and try to remove this PFCL after a couple of months, there's a high chance that you can remove the oil because it's lighter, it comes up. But the PFCL stays there, and as soon as you start trying to aspirate with whatever instrumentation you have, either an extrusion or a flute, it just doesn't come out. Okay, so now you go in and say, I'll use active extrusion, 600 vacuum, it's just PFCL, it should come out, but it just doesn't come out because it's like a heavy silicone oil sitting lower down, doesn't float up, doesn't get aspirated out. So it's a problem. It's a unique challenge. It's not emulsification, but the PFCL acquires the properties of silicone oil. So I just leave these eyes, even if otherwise I thought I could remove them. Yeah. The other question, sorry, you said how much to leave. So I would say about 60 to 70% silicone oil, but it can titrate based on the retinectomy. So when the patient is lying on the table, when you dry the edges of the retinectomy, you first filled it with PFCL, now do a fluid air exchange, and you definitely want the edges of the retinectomy to be covered in the supine position. So these patients need a flat position post-operatively. At least in the lying down position, the PFCL should be completely covering the retinectomy edge. And if it's anterior, even in the sitting position, it's looking good for them. Yeah.
Thank you.
Yeah, yes, sir. I would like to ask one question. Sir, excellently told by Dr. Raja sir that we do find impossible or very difficult to take out the PFCL in such cases. I myself in these type of cases do surgery in two-stage manner. So especially in cases of GRT and all, first the close the cavity under PFCL, and after 10 days or even 2 weeks, I took out silicone oil and PFCL and then top it up with silicone oil. So, sir, what problem I face is, as you told, in such a cases, silicone oil and PFCL, I think that interface between the two, it becomes very sticky and turbid. Sometimes it causes opacification. So while taking out the PFCL, it doesn't come out from the top because it sticks to the flute cannula or even the active section. It just doesn't come out. So sometimes I use cutter also to clear that turbid, frothy kind of thing which is sitting on the top of PFCL. So my question is, in long-standing cases, in visual acuity wise, if not emulsification, do that turbid interface hampers the vision or some opacification or in such cases, or in long-standing for this when we do this sandwich technique?
So as I showed in my pictures, the last one of the last slides, multiple patients' eyes with the silicone oil and PFCL, I did not see any turbidity in the interface. But you can make out the interface. But I leave them at the end. So they are lying much inferiorly. So they don't disturb the vision in these patients. Yeah. Bhavik?
Yes, Dr. Raja. Thank you for your talk. Maybe I missed it. What is the duration, the maximum duration you have kept the sandwich in a patient?
I think probably I'll have to check, but it's definitely more than 3 years.
Oh, okay.
But I can tell you the exact figure. Is it 5 years or more? Yeah. But
Okay.
it's quite prolonged, yes.
Yeah. So I have also been using this technique. One experience I just want to share that sometimes the silicone oil bubble gets entrapped under the PFCL, and that becomes very difficult to remove. It just keeps on moving and doesn't come out. I don't know if you have experienced that removing this entire mixture
Silicone oil getting trapped in
under
PFCL.
under the PFCL bubble. Yes.
So it's like you can assume whether it's the silicone oil which has got trapped or the PFCL which has got trapped. So the thing is, both of them share
As you
either the
explained, PFCL
consistency,
takes the
the
property of
properties later
silicon oil.
on. It
Yeah.
becomes viscous, so you think it's silicone oil, but
Correct.
it's heavy, so you think it's PFCL. But I
Okay.
don't remove it, so I don't. So there's no
So
point
you don't
chasing.
remove it. Yeah. Okay.
I just leave it.
Sure. Thank you so much. Thank you so much, Dr. Raj.
Thank you
Thank
so
you,
much.
Arun sir. Just one observation regarding the point you made about toxicity. In the images you showed, the level of PFCL was below the macula. So it's a 60-70% fill of oil versus
Yeah,
PFCL.
yeah,
So since it's below
yeah.
the macula,
More,
could that be the reason why there's no toxicity?
yeah. So more oil for sure. So either 60% or 70% should be oil. Yeah, that could be the reason why not have toxicity. But yeah, that's good.
Thank you so much, sir.
Okay, thank you. Thank you.
Thank you.
Thank you, sir. Thank you.
Thank you, sir. Arun sir had to leave at 8:15 sharp for another meeting, and we are so far going on time. And Komal ma'am is here. Good evening, Komal ma'am, for being here. Dr. Komal Agarwal is a consultant with ASG PNK in Lucknow. She was a faculty member at LV Prasad Eye Institute in Hyderabad, where she's worked extensively on pediatric retina and retinopathy of prematurity. She was a fellow with Subhadra Jalali ma'am before starting a very busy pediatric retina OPD herself, which I got to learn from as well as a fellow. It's a privilege to have you here, ma'am. Please do share your slides and we can start with your talk.
Thank you. Thank you, Arjun, for having me here. I'm just sharing my slides. Please let me know when they're visible. They are?
Yes, ma'am. The slides are visible and you're audible.
Okay. So I would be talking on managing pediatric retinal detachments. So what's different? What is different about pediatric detachments and why are we speaking of them in a separate talk? Before we start thinking about managing these cases, there are some anatomical considerations that we need to have. The first and the foremost being that these eyes are small. They have a larger lens, they have a steeper cornea, and the axial length is much smaller, especially if you're considering neonates. So obviously we'll have very less space for the movement of our instruments. We will need smaller lenses, smaller viewing systems, and uh, and make some or the other adjustments to our underlying the instruments that we have to make them more usable in these eyes. The sclera is pliable, they have very less tensile strength, and in most of the cases, the sclerotomy will not be self-sealed. So it's a good idea to suture them. Now, talking of the neonates, they have a poorly developed pars plana, especially if you are tackling detachments which are associated with ROP. So the port entry is through the pars plicata, which is around 1 to 1.5 mm from the limbus. And you can imagine, so if you have to spare the lens, if you're doing a lens sparing vitrectomy, your sclerotomy has to be more vertical inside the vitreous cavity so that you don't injure the lens and also you don't injure the retina, which is already detached. However, if you are dealing with cases where the retina is dragged towards the lens or towards the ora, towards one side, then it's a good idea to sacrifice the lens. And in these cases, we make an anterior entry, which is mostly horizontal, directly into the lens, sacrifice the lens, and then go ahead from that. Now, in most of these tractional detachment cases, it's not required to really do the PVD or create a PVD, and we'll talk more about it when we go to the tractional detachment cases. But even in the reg cases, these pediatric detachments will have a very densely adhered vitreous, and in such cases, PVD is a task. Many of these cases will also have a persistent tunica vasculosa lentis, and that definitely needs removal. So the spectrum of retinal detachment in these eyes will obviously go from tractional to reg to combined and exudative. But since this being a surgical class, we would be talking on the first three. Again, before going to the surgery, there is a huge preoperative considerations that we have to make, starting right from the history. The birth history in these cases is very important. Actually, the birth history is the only thing which will help you differentiate between a stage 5 ROP or a stage 5 FEVR. The family history will give you lots of clues, especially in FEVR cases and other syndromes. The systemic status, we have to look at the child as a whole. You have to look at the skin, the stature of the kid, and so many other things, the bones, because it's known that a lot of these retinal detachments are associated with multiple syndromes. We all know, and we have all faced that the OPD examination of these little kids can be an issue. So ultrasound I consider as a must, even if you are able to locate the break, even if you are able to understand that this is a reg detachment, I would still do an ultrasound to make sure that I'm not missing any underlying disease or any underlying pathology which might be missed on my examination. And when I can't do that, when I'm not sure, many a times an EUA is something that I prefer to do before I plan the surgery. And of course, we have to look at the anterior segment status, how the cornea is, the lens, any scleral thinning, whether it's associated with glaucoma or increased horizontal corneal diameter, all of which will have a bearing on the decisions that you make preoperatively and intraoperatively. General anesthesia is a huge concern, especially for the ROP kids. And also, a huge amount of time is required for the parental counseling to adjust their post-operative expectations and to tell them about follow-up and the management of long-term complications. So we'll start looking at some cases, and I'm starting, of course, with my favorite tractional detachments because I've worked extensively on ROP. TRD in these kids can vary with etiology, whether it's ROP, whether it's the whole of the FEVR spectrum, whether it's PFV or Toxocara. But in all these cases, the basic rules are the same. We have to remove traction and we don't have to create any breaks. So this is basically a video, a small clip of a stage 4A ROP that I was operating. And you can see I'm just taking care of the vectors where I am removing the connections between the elevated ridge and the retina and the disc. And in the next video, I'm taking care of the vitreous adhesions between the ridge and the ora. So that is all what is required in these eyes. And we just remove all the traction, we put some air, and we move forward. These detached parts of the retina will settle down on its own over a period of time, and we don't want an absolutely attached retina on table. Moving on to a stage 5 ROP case, here just a little bit of modification. As I had mentioned earlier, we have to sacrifice the lens, sometimes the iris, to achieve a good view of all the membranes, remove the posterior capsule, and then do a bimanual dissection to remove all the retrolental membrane and all the membranes that we can remove. But again, the most important thing here is to consider that we do not have to make a retinotomy. We will never achieve a absolutely attached retina like you have in reg detachments in these eyes. We just have to remove traction, put some air, and let the retina fall back into its place as the eye grows. A very similar thing in persistent fetal vasculature as well. This is again some eye and one 3 months old full-term baby which had presented to us with poor fixation with central TRD, and you can see the stalk which is coming till the lens. It's important again just to cut the lens, cut the stalk, do some vitrectomy around the TRD. Do not create a PVD, and just open the funnel by removing the membranes very, very carefully, bimanually if required, and just put some air and end the case and let the retina fall back as and when the eye grows. Now, when I come to the reg detachments, scleral buckle is still the procedure of choice for a number of reasons. One, because it avoids difficult PVD. In this cases, it avoids complicated vitreous dissections, especially if these cases are associated with hereditary vitropathies. It avoids mostly all the tamponade-related issues and the long-term complications of cataract and glaucoma, and also avoids the positioning difficulties. And this is a small clip again, just to show you that a chandelier can many a times be used to bypass the use of the indirect ophthalmoscope while you are doing a scleral buckle. for steps like when you're doing a cryo, or if you want to do the SRF drainage under visualization. But obviously there will be cases which will not be amenable to a buckle, and in those cases we will have to do a vitrectomy. In these cases, the major challenge is the creation of a posterior vitreous detachment. And in this clip, you can see I have stained the vitreous. I tried peeling it, the posterior cortical vitreous. I re-stained it again. I used PFCL as a third hand to stabilize the posterior pole. I'm using forceps. Many a times you can use scraper. We can use hoops, as Dr. Aryan was mentioning. But again, it might not be possible to remove all vitreous or all cortical vitreous as much as you would have wanted. But it is important to remember in all pediatric eyes to do no harm. Just because you want to remove all of this, do not go ahead and create multiple iatrogenic breaks, because in those cases, the risk of PVR would be much higher and you would ultimately lose the eye. So you peel till you can, put an additional incerclage if it is required, and then you trim the rest of the vitreous, put some oil and leave the eye. Many of these cases will be rescued just because you had that restraint to stop. A short word about the tamponade. In these cases, both gas and silicone oil can be used. I prefer oil, even though it has a risk of glaucoma, cataract, and BSK, but it does make my post-operative examination much more easier, and I prefer long-term tamponade in the pediatric eyes. A lot of these eyes, we know, and it has been reported that around 15 to 50% of these eyes are a part of systemic syndrome, with Stickler syndrome being most common. So I'm just mentioning a few cases that I had. Now, this was a 12-year-old boy with short stature, some epiphyseal dysplasia of the face, had lost the left eye due to RD, had presented with a total cataract and nystagmus in the right eye, and the B scan showed this detachment with some subretinal hyperreflectivity. Mother had a similar build, had nystagmus and poor vision, and had a history of retinal detachment surgeries in both eye. Now, 3 surgeries later, and putting in silicone oil of 5,000 centistrokes, this is the retina that I was able to achieve, but I do not have the guts to go back again and remove the oil in this case. And despite the retina looking this way, the vision still is about 2400. Again, one of the 30-day-old neonate presenting with leukocoria did not really fit into the ROP spectrum, as was nearly term. I decided to do a family screening, and this was the father's fundus, where you can see NVE in the right eye and some atrophic holes with peripheral avascular retina in the left eye. We did a gene testing for this baby, and he came positive for mutation in NDP gene. Now, why is this important? It is important because I know that this is FEVR and the retina will be dysplastic. It is not a stage 5 ROP, and so my stage 5 ROP surgery will not have the same effect in this eye, and so I decided to leave it alone. A very similar case, right eye totally closed funnel TRD, the other eye had an APROP like picture along with some traction, but you can see the skin lesions here, and it's a clear-cut case of incontinentia pigmenti. So why is this important? It's important because many a times the retinal surgeons are the ones who discover these syndromes, and it's well said that retina is a window to the body. It helps us in bringing out comprehensive care for our patients. It also helps us making intraoperative and postoperative decisions, and to decide the prognosis in this eyes, and to actually decide whether we want to operate or not to operate. But also it will give us an idea about the fellow eye, whether that will get involved, what is the percentage, and how do we decide our follow-up. A very short case about the combined attachment. Now, this is a 13-year-old with an old history of ROP sequelae. You can see the fixed folds here. He came with a sudden decrease in vision, and you can see the rec component along with the fixed folds. Now, this break was a little posterior. I was not sure it is going to come on the buckle or not. I definitely did not want to do a vitrectomy. I consulted Dr. Subhadra, and she decided to do what she calls as a scleral imbrication. Now, this is very similar to basically how an invagination works. We do similar steps as buckle, and the only thing that we do is make rectangular scleral flaps. We dissect it on both sides, and this is placed basically depending upon where the area of traction is or where the break is. And once we have dissected both the flaps, we use 50 Dacron sutures to oppose them over each other. And although I initially thought that it might not be that easy, how will it come over each other? But once you actually have done this dissection, the eye becomes quite soft, and it's not a very difficult task to oppose it. It gives a sort of scleral shortening effect, which will help the break to come over the buckle, and we can obviously use an additional buckle for support. And this is the post-operative picture. It doesn't end with surgery, and this is my the last part of my talk. This was a stage 5 ROP baby that I had operated. This was a post-operative picture, a very open funnel, attached macula, attached retina, and a very few peripheral folds. I was a very happy surgeon, and you can see in this video, the child had started fixing and following light. The parents were happy. I was a very, very happy surgeon. But then 2 years later, the baby comes to me with this. And I learned that it doesn't end with surgery. Many of these cases, because the retina is still avascular and ischemic, might go into a neovascular detachment. So this is just one of the complications that might happen, and we have to be always on a lookout for cataract, glaucoma, IOL-related complications, amblyopia, obviously, and in worst-to-worst cases, neovascular glaucomas. So every case teaches us something. There are a lot of anatomical and functional challenges that you face when you are managing these pediatric patients. But once successful, the reward is unparalleled. Thank you.
Thank you so much, ma'am, for bringing out those very challenging cases and not just telling us what to do, but what not to do. Do no harm in a pediatric eye is a very important point you brought about. And the other important point you brought about is that it doesn't just end with surgery. We need to follow up and be vigilant after that too. For lack of time, we'll just take one question for ma'am, and the rest of them can be continued in the chat box. Dr. Jayant Kumar can just share his screen while the question is being taken up. If any of the panelists have any questions or even the audience members have any questions. I think for most it's just a learning point. Pediatric retinal surgery itself is very challenging. So thank you so much for that, ma'am. And our next speaker for today is Dr. Jayant Kumar. He is a consultant retina surgeon with ASG Ranchi, and recently he had a very interesting presentation at the APVRS meeting where he spoke on PVR RDs and chronic RDs, and he'll be talking to us today on tips and tricks to manage chronic RDs, something that we face, all of us as retina surgeons face in practice. Over to you, sir. Your slides are no longer shared. You can please share your screen again.
Thank you for the kind introduction. I'll just try again.
Yeah, it is visible now.
But I think there is some issue with am I audible?
Yes, sir, you're audible. I think
Okay.
that just said continue to share and should
Yeah,
continue.
but it's just not getting clicked. Mhm.
If Vikas
In
Ambia
that
sir
case,
is
yeah.
here, should we
Do you
move
have
on to
any
the
other
next
speaker
talk
ready?
and then
Yes.
we'll come back to your talk after this?
Yeah. Yeah. Otherwise, I'll just try
Right.
once again. Yeah.
I think Vikas sir is here.
Yeah, I'll just try. Can you see my slides, Arjun?
Yeah, it's visible now, sir. Yeah, so we'll go to the third talk in place of the second one, and then we'll come back to the second one after this. Dr. Vikas Ambia is a retina surgeon at the Armed Forces Medical College. He is a surgeon who's known to take up challenging cases and an innovative surgeon. To his credit, he has over 50 publications and he always has some interesting cases to show. And today he'll be talking to us about managing recurrent detachments in viral retinitis, something which again is a very challenging scenario for all retinal surgeons. Over to you, sir.
So, good evening, everyone. First of all, I thank team ASG and Satvik Eye Hospital, and especially thank Arjun for giving me this opportunity. So, I'll be sharing my experience of using fibrin glue in cases of recurrent RD post-viral retinitis. So we know that CMV retinitis and acute retinal necrosis are the commonest causes of retinitis in cases of HIV. So basically, the pathology causes a full thickness necrosis in the retina, which increases the chances of formation of atrophic holes in this retina, leading to retinal detachment. Typically, it happens mostly after the retinitis has resolved. Now, in CMV retinitis, these holes generally occur at the junction of necrotic and healthy retina, whereas in acute retinal necrosis, you'll see that you'll find multiple peripheral holes in the peripheral atrophic retina. So, what is the surgical challenge that we face in these cases? First of all, you'll have multiple breaks in the periphery. There's going to be an extensive traction, vitreous traction, because of PVR. And no matter what you do, because the retina is already atrophic, you'll never be able to achieve a good choroidal adhesion, whatever be the method of retinopexy that you're using, be it laser or cryo. So since you're not able to achieve a robust retinopexy, there's a very, very high risk of redetachment in these cases, even if you've provided a silicone oil tamponade. Then there's a second factor which acts in these cases. Now, because of immune suppression in HIV, the wound healing is delayed. So there's always a reduced choroidal inflammation after your retinopexy, and again, all these increase the chance of redetachment after surgery. So what happens? Either there is reopening of pre-existing breaks, or new breaks might form at the interface of necrotic and healthy retina. So a lot of times you have to take up these patients with multiple surgeries to achieve your aim. So I'm sharing this first case. You can see that this is around 28 years old young male who's HIV positive. He came to me with, this is the primary surgery I'm talking of right now. You can see a patch of atrophic retina because of CMV retinitis in the past. It's a healed lesion, but you can see there is total RD, and you can see there are star folds in the temporal side. So generally, I try to augment all these cases with a 240 band encerclage, because that drastically reduces the chances of recurrence in these cases. Now, this, what I'm showing, is a routine RD surgery, since it was the primary surgery that I was doing. I made sure that I make the retina free from all those star folds. So I did stain the retina with trypan blue and did a good membrane dissection to make sure that the retina becomes free. So I'll just fast forward this part. So you can see, so I'm doing membrane peeling to make sure that all those epiretinal membranes are removed. So this was, and I gave silicone oil tamponade. So this is the first post-op day. You can see that there's a very well attached retina. The boy continued to have the same status for almost a month, but he comes back to me after a month with this kind of a picture. You can see that there's an atrophic hole at the junction of healthy and necrotic retina over here. Now, what is the peculiarity of this break? This break is very, very close to the optic disc, and it's lying right between two major vascular trunks. Hardly any length or area of retina left for me to do an effective retinopexy in this case. So this is the surgical video I'm sharing. So I again go ahead with, it's an already vitrectomized eye, so there's nothing much to do in vitrectomy. So I start staining the membranes. You can make out that there are star folds again at the same sites where I had them during my primary surgery. So first of all, I again get rid of those epiretinal membranes. This is, I think, the most important step in post retinitis RDs. They will have a lot of PVR, and unless you get rid of this PVR completely, they are going to keep coming back to you with recurrence. And secondly, I like to give encyclage in all these cases, just to increase the chances of your anatomical success. So yeah, I'll skip this part. So I did good membrane peeling in this case. Sorry. To make sure that the patient doesn't come to me with recurrence, I also did ILM peeling at the sites of these star folds. And once this was done, I used the same site, the atrophic hole, as a site of SRF drainage. There's hardly any area left for me, so I just applied a single row of endo laser spots around the break. And this is the point which I want to emphasize. Here's where fibrin glue comes to your rescue. So I applied fibrin glue to the break. What you need to be careful about is it's better to inject the thicker part first so that it doesn't spread to whole of the retina, and followed by the thinner part. And you can see that whitish kind of precipitate which is covering the break now. And of course, the kind of tamponade which I gave was silicone tamponade in this case. So this was the post-op status. The patient maintained the status for till I've been following up this patient in fact till present. So this is the silicone oil filled eye with well-attached retina. I removed the oil after 3 months, and the patient had a good visual recovery. This is another case. Now this is a 38 years old lady. She's HIV positive. She had undergone surgery. I had operated in this case for RD after acute retinal necrosis, resolution of acute necrosis. So I did give her encerclage, and she did well for almost 2 months. But after silicone oil removal, she came back to me with recurrence. As you can see in this case, there's an atrophic hole which has come over here. There are multiple holes which are not visible in this photograph. You can see subretinal bands. That means the RD has been chronic for some time now and extensive PVR. So I took up this case. Again, not much vitrectomy to do in this case, but I had to shave off the residual vitreous base meticulously in this case. So after shaving off the residual vitreous base, you can see there are multiple holes in the periphery and a good encerclage indent you can see from the previous surgery. So I want to make sure that this person, this lady does not come back to me with any macular contraction. I did a good ILM peeling in the macula under PFCL, of course. And I use the PFCL for SRF drainage through the same peripheral retinal holes. I did not create any nephrectomy for SRF drainage. So a good ILM peeling in the whole of the macula. And in the end, a good retinopexy around the breaks. But the step to be emphasized, again, I used fibrin glue in all those 2 or 3 breaks which I had in the periphery. So again, silicone oil tamponade. This is her post-op result. Now, again, she's been maintaining vision for almost 9 months now. I removed the oil after around 4 months in this case, and the retina stayed attached. So in the span of almost 4 years, past 4 years, I have operated on around 40 plus cases of retinal detachment post-viral retinitis. I had recurrence in 12 of these eyes. And in the 12 of these eyes, I have a follow-up of around 9.5 months, maybe 9 to 11 months. I had reattachment in all these cases. I used fibrin glue in all these cases. There was significant improvement in visual acuity, of course, because the retina was attached. And roughly, I would say I remove oil in around 3.5, after around 3.5 months in all these cases. Sort of the main benefits which are observed after using fibrin glue in these cases. Firstly, fibrin glue gives you an immediate mechanical sealing of the break. So it doesn't allow any egress or ingress of fluid through the hole during tamponade. Secondly, whatever retinopexy you're doing, whether it's laser or cryo, it takes some time for the biological adhesion to take place. Till the time, it's your fibrin glue which helps you buy time. So it gives you that extra time for the retina to become adhered. Because this retina post-retinitis, it's an already compromised retina. It's an atrophic retina. The retinopexy is never going to be as effective as it is in a normal healthy retina. in primary RDs. Secondly, since you don't have to do now excessive laser in these eyes, it avoids any excessive thermal damage to an already compromised retina. In my cases, I did not observe any toxicity or inflammation or any adverse effects. Secondly, it also shortened my surgical time because in a lot of cases where otherwise I would have done a retinectomy, it saved me from that extra step. The extensive laser, which would have been required otherwise to be on a safer side, which you normally do, even that was avoided. So generally, the surgical time was also shortened by the use of fibrin glue. Now, what are the limitations? Firstly, it's a substance which is going to spread on your retinal surface. So you have to be very, very careful under air when you're dropping those drops of fibrin glue. They should be falling exactly on the break. And to limit its spread, always start with the thicker part first, followed by the thinner part. Sometimes you might have to use your forceps to lift up extra fibrin glue from the periphery and heap it over your break. There is a theoretical risk of inflammation, but I've not seen any in my cases till now. Secondly, it forms a whitish precipitate on your retina, so your vision is immediately going to be obscured. The underlying retina won't be seen as clearly as it was before you applied the glue. So it's best to do a good cautery around the hole to make it visible, and then apply the glue over it. Lastly, it's the cost and availability, not a major factor. So to conclude, I would say firstly, the patient selection is crucial. You also always want to apply fibrin glue over breaks which are very, very well localized and have minimal PVR. In case there is extensive PVR, you have to augment it with other steps. For example, you might have to do retinectomies. You might have to do an encerclage, otherwise which you might not have done. But still, whenever there's an extensive PVR, it might not be as successful. So to conclude, I would say that it's a safe, effective, and minimally traumatic. I would always call it an adjunct to your primary procedure, which you would do in a case of recurrent RD post viral retinitis. I finished, Arjun.
Thank you so much, sir. Those were some very nice cases you showed and a new approach to managing these challenging cases. I'd like to open up this session for questions if anyone from the panel or audience has any questions to ask. So just one thing I wanted to ask you is that you've used this in recurrent detachments. Are there any cases of viral retinitis where you would consider using this in the primary surgery itself?
What I feel is, irrespective of this detachment being primary or secondary, whenever you feel that you're not very, very sure of the kind of adhesion you're going to acquire with your retinopexy, even if it's a primary surgery, you can always augment it with fibrin glue. All cases of any inflammation causing atrophy of the retina and you are dealing with an RD, you can augment it with fibrin glue. But nothing beats the primary steps which you are otherwise supposed to do in all these RDs. Just
You're
as
right.
in,
So
yeah.
your findings align very well with the GUARD 2 report published from LVPI by Dr. Thakkar and Dr. Tyagi. So they used it for complex retinal detachments, and those are also recurrent cases.
In
So
fact, I will acknowledge, yeah, I got inspired from his presentations only, but I thought why not use it in post-retinitis RDs also.
So that's a new nice approach to it, and the results are very promising. It's something I think we can all consider in these cases, especially the recurrent ones. And you very nicely listed out the indications also that where there's a minimal PVR with a clear-cut break, which is identified. Thank you so much for this presentation. If no more questions to stick to time, we'll go to the next stop. Any other questions, if there, can be taken up in the chat box. Thank you so much for being here, sir.
Thanks, Arjun.
We'll just
Thank you.
go back to Dr. Jayant Kumar, sir. If you can just share your slide now.
Yeah.
Vikas, sir, you can stop sharing your screen, please. Thank you, sir.
So are my
Yeah, it's
slides
visible now, sir. It's visible.
So thank you, Dr. Arjun, and thank you, Academic Cell of ASG, for giving me this wonderful opportunity today. And I'll be talking about managing chronic retinal detachments, tips and tricks. So chronic retinal detachments often for young surgeons are very overwhelming. Just the sight of it can give us a lot of nightmares. Right a day before the surgery, surgeon may think about is he going to manage the case, and all nightmares about recurrence keep coming. So the first thing is the mental block, which we need to overcome. The second thing is that membranes are often having firm adhesions, and it's really challenging to deal with them. There's often less working space, as Dr. Komal had also pointed out. And subretinal migration of infusion is something which is, again, quite a challenge. Just a second. So the next difficulty again is managing subretinal PVR. And recurrence is again another challenge, which is often something which surgeons have to deal with. So some of the solutions which are available, I have listed them over here, and two of them which have my own personalized touch, I'll be dealing with them in detail. One is best vitrectomy and the second was customized long self-retaining infusion. So best vitrectomy is something I have come up with. It's a kind of a modification of buccal vitrectomy. In this, what we do is like a routine buccal vitrectomy, like passing a 240 band encirclage and say 25 gauge vitrectomy. We do two additional steps. One is external drainage of subretinal fluid, just like scleral buckling, and second is injection of saline through transscleral route. Now, the purpose of these additional steps, well, it is to bring to use the principles of Pascal's law. Pascal's law states that when pressure is applied to an enclosed fluid, it gets transmitted without a change in magnitude to every point of the fluid and walls of the container. So here we can see applying the same principle in cases of chronic retinal detachment. What we do is that after drainage, the globe is hypotenuse. We pull out all four recti muscles and then go through transscleral route and inject saline. And this we can see that expands the entire globe. And if you if you'd like to know about the utility, on the left hand side we have an image from a buccal vitrectomy case where I had not done best vitrectomy or these external drainage steps. You can see that managing these membranes are extremely difficult. There is very little working space. The funnel is closing. While on the right hand side, a case where I had done external drainage and saline injection, I could get much more working space, and there is much easier, like you can say there are favorable changes in membrane and hyaloid configuration and severity of adhesion, and we can induce PVD or deal with membranes in a much easier manner. It's just like the way hydrodissection creates a lot of ease in dealing with cortex in cataract. Similarly, I feel this fluid jet does help a lot in managing these complex cases. So I had the opportunity of presenting my work and this best vitrectomy technique at ASRS 2025 at Long Beach, California. And I had presented the results of doing these cases in around 46 eyes, this using this method in 46 eyes. And overall, the results, like I had close to 80% single surgery anatomical success, which was quite significant compared to many other publications on chronic retinal detachments. So let's look at some of the cases. This was one case which where child had a very long standing chronic retinal detachment. So we can see that managing the membrane or the working space increased a lot after we went ahead with the two maneuvers which I just mentioned, and we can deal with membranes in a much easier manner. And eventually the funnel opens up well. We can laser and use silicone oil, and on the right hand side we can see the post-operative image. The child did pretty decent anatomically. This is another case where I went ahead with the same principles and could open up the case well, the funnel well, and eventually patient had very good visual outcome and anatomical outcome. This is a third case where I did the same. And this is this is a fourth case which has a very long follow-up too. So in this case I removed oil almost around a year after primary surgery, and in the like just 2 days back I saw the 2-year follow-up of this case, and patient is doing extremely good, maintaining 6 by 36 partial vision with some residual folds. Coming to the next challenge, which often which we all face while dealing with the chronic cases, is migration of infusion. So what happens is there is a lot of anterior PVR, and often the infusion migrates subretinally, or in cases of RD with CD, so in the suprachoroidal space, and we have extreme difficulty in managing the case further. So we can see here just one example where the infusion has gone subretinal. So this is another thing which really troubles us when we are dealing with very chronic cases. So I came up with a customized self-retaining long infusion, and customized I say because it can be of any size depending on the case. I even choose it up to 8 or 9 millimeters of infusion size. So what we do is we use an extrusion cannula, cut it the tip to the size which we need, and then I take up the uh, soft part of intracath, and the size is generally one size engage higher than the size of the extrusion cannula which I have taken. And on the right hand side we can see that I have a small sleeve of the intracath put over the infusion or like the extrusion cannula, and this when we screw it up in place of infusion, it acts like a self-retaining infusion. Even in phakic cases I have done it, and that really helps us intra-op, because you can see in these complicated cases the infusion is right almost up till mid vitreous cavity, and you can see it, visualize it during your surgery, and you are 100% sure that it's not going to slip during your surgery. So this is something which is a second solution. Next challenge is often subretinal bands. So what happens is like, especially young surgeons, they find that subretinal bands, they don't really come out, or like even if there's a retinotomy being done, it's quite difficult to hold it or remove it. So one is the conventional thing, like this is one case. What I do is I strum, release, and then remove it like a guitar string. So what we do is when we strum the subretinal band, we can see that it starts getting detached from the underlying retina. So in slow motion, I'll show in this place that when we keep strumming it, we can see that it starts getting detached from overlying retina. And then once it is free, we can keep removing them from multiple places. So in this case, eventually I could find out some areas from where I could remove them, and eventually all subretinal bands could be removed and patient had a well settled retina. So the point is sometimes these subretinal bands can be extremely posterior close to the disc, and it may not be wise to go and make a retinotomy that posterior. So for that we have subretinal approach too. So what we can do is we can go ahead from around 9 to 10 millimeters from the limbus, and this is a band which I am removing from the subretinal root. So we can go and just try and grasp the subretinal bands, and then go ahead with the swivel motion. So the way it has been described from the pars plana route, we can try and do it from subretinal route as well. So the advantage with this technique is that you don't have posterior retinotomies, especially in such cases when there is a solution which is another solution which is scleral buckling. So uh, there are surgeons who would be like scared of going ahead and doing surgeries again and again, removing oil and removing the membrane. So we really don't need to remove silicone oil if we have to deal with some limited PVR. And there are multiple techniques described in literature, and I also have been practicing it. No need, I don't really remove oil if there are some membranes forming. We can just go inside and remove those with oil in situ and use some top up oil if there is any loss. Also, as Dr. Raj Narayan sir already said, methotrexate has been in use for quite long, and the challenge is multiple injections, weekly injections. But there are publications which say that even you can go ahead with 4 to 5 injections till SOR, and this is something which often makes the job easy and limits PVR change formation. So, if I see the list of challenges which I had mentioned right in the beginning, the first one can be dealt with by overcoming the mental block. Firm adhesion and less working space, the technique which I have described, best vitrectomy, I mean, does help. We just need to use it. Once surgeons use it, they'll realize that there is drastic improvement in dealing with membranes, the way we can deal with membranes. Customized long infusion which I use, I really like the way they work and provide stable and uh, say confident infusion throughout the surgery. For subretinal PVR, I think subretinal route is a pretty good option. Without creating retinotomy, we can actually deal with them, especially when they are very posterior. And for recurrence, methotrexate and membrane removal under SOI under oil does help us a lot. And additionally, scleral buckling and two-stage surgery, the one which was described by Rajnarayan sir too, do help us in dealing with many complicated cases which are otherwise difficult to handle. So that's all which I had to talk about in this talk today. Thank you very much for your patient listening.
Thank you so much, sir. That was an excellent presentation, and you very nicely split up the challenges for us to see. The long infusion cannula in particular is something very useful because I think the 6 cannula is not available anymore. At least I have not been able to find a replacement. So that was a very nice thing. And even the point on best vitrectomy was something very interesting. Our next talk will also talk about injecting something into the eye before the surgery. So that's a very nice point you brought up. I'd like to open this session up for questions from the panelists or the audience. I think everyone is just amazed by the surgeries to ask any questions. But thank you so much for that excellent presentation, sir. We'll go ahead to the last talk of this session by Dr. Devesh Kumawat. Sir, you can share your slides, please. So, Dr. Devesh Kumawat is a faculty at RP Center, AIMS. He's very active academically and is a very active surgeon as well. And he'll be presenting his talk on pivot in RRD and CD, something which he also presented at VRSI. Thank you so much, sir, for being here and giving this talk.
Thank you, Arjun. Is my slide visible?
Yes, sir. Your slides are visible and you're audible.
Okay. So at the outset, I would like to thank the academic cell of ASG for inviting me over here to talk on this different approach to RRD with CD. So if we look at RRD with CD, it is a very challenging surgical scenario because of the marked hypotony which is present in these eyes, marked intraocular inflammation, and then high propensity for development of proliferative vitreoretinopathy in these eyes. Now, the recurrent detachment is again a concern, and the success rate with the scleral buckling and pneumatic retinopexy is very dismal. So, the standard of care remains vitreoretinal surgery with silicone oil injection, a longer tamponade, preferably with an encircling element, usually a band or a buckle. Still, with this combined approach, the single surgery success rate they are limited to around 60 to 70%, which is far less than the success rates in RRD without CD. Now, there are a number of surgical challenges as well that you encounter while doing surgery in RRD with CDs. Namely, it is the mainly it is the suprachoroidal or the subretinal placement of infusion or instruments that is the most challenging, especially for young surgeons or fellows. Then increased mobility of the peripheral retina that leads to high risk of iatrogenic breaks. Then, if the choroidal detachments are not drained intraoperatively, or they are still residual at the end of surgery, then the break retinopexy might not be possible sometime, and then silicone oil could be underfill, which can lead to a reduced tamponade function later on. Now, most of the vitreoretinal specialists would start these patients on oral corticosteroids for a couple of days and wait for the CDs to reduce before performing the surgery. However, if we see the recent evidence and the recent meta-analysis, they have shown that the effect is same, irrespective of whether you give a steroid pre-treatment in these eyes. So it doesn't support delaying the surgery for steroid pre-treatment. And on the other hand, it can a delay in surgery can lead to further setting on of the PVR, and that could be counterproductive. Now, most of us would have resorted to intraoperative CD drainage. Now, unlike the conventional 20 gauge vitrectomy system in which the sclerotomies they easily allow the suprachoroidal fluid to leak out and the choroidal detachments they disappear. But with MIVS, especially with 25 gauge surgery, this is not the case, and the CDs often remain in the operative period even till the end. Now, the drainage, so then one has to resort to either a scleral cut down or a trocar assisted drainage, which might be technically challenging, and there are risks associated with it, such as those of choroidal bleed or iatrogenic retinal damage. And even after that, the choroidals they do not drain completely. Now, if you see the hypothesis, the pathophysiology of RRD with CD, it is basically the increased uveoscleral outflow that is happening, which is leading to hypotony. Now, this hypotony, along with inflammation, leads to transudation from the choroidal vessels, This transudation leads to further extension of the choroidal detachment, leading to ciliary body detachment. Once the ciliary body detaches, the aqueous production also reduces, which is also um, 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 which also gets propounded because of the inflammation which is associated, and therefore there is a vicious cycle of RD, CD, and inflammation. Now, if we only are going to focus on the inflammation part, then we are missing the hypotony over here. And if we really want to stop this vicious cycle, then we need to target both the inflammation and hypotony. Now, with this hypothesis or rationale in mind, we thought of injecting something into the intraocular space that would improve the intraocular pressure, break this vicious cycle of hypotony and then CD. So we initially started with intravitreal injection of BSS in two of the eyes. We tried it, but the intraocular pressures, they again returned to the baseline low intraocular pressure. The hypotony again came back even as early as 2 hours after the injection, and the intraocular pressures in CD, they did not improve even a day after. So then we thought that it is maybe the BSS is getting absorbed quickly through the uveoscleral pathway, and that's why it's not helping. So we thought that we need something which could retain for a longer period of time, and then we shifted to 1% Helon injection in the vitreous cavity. Now here we got some promising results, and therefore we conducted this study in which we evaluated the safety and efficacy of preoperative intravitreal viscoelastic injection, that is pivot, in facilitating early and safe surgery in RRD with CD. Now, it was a consecutive case series in which we included patients in which the in which the CD was extending to at least the equator. There were massive mounts in at least one or more quadrants, reaching till or beyond the equator. And we did a thorough baseline assessment of these patients. And to quantify the choroidal detachment, we did a B scan USG, and we measured the CD height in all the four quadrants, and we calculated a cumulative score as well as a mean score. Now, in addition to the standard of care, that is the topical difluprednate that we use in all patients, along with hometropine and oral corticosteroids wherever possible, we gave a preoperatively, we gave an intravitreal injection of 30% of 1% Helon using a 30 gauge needle, and we injected the Helon into the anterior vitreous cavity through the pars plana route, and the target was to achieve a digitally normal intraocular pressure, and the volume of intravitreal Helon that was injected was ranging from zero point 0.4 to 0.8 ml, that is nearly half to 1 ml, 1 full vial. Now, the outcomes that we assessed were intraocular pressure 2 hours after the injection. On the day of surgery, again, the media clarity and CD height was repeated on the day of surgery. During surgery, we noted whether the port entry or the instrument entry was safe for all the locations. Was there any residual CD mount at the beginning or at the end of surgery? Any iatrogenic breaks that might have occurred because of the needle injection, and then we, in the post-operative day 1, we also noted the intraocular pressure and silicone oil fill. Now, these are the details of the initial 8 cases in which we thoroughly or comprehensively we assessed the choroidal detachment height, and the mean age of these patients was 50 years. The duration of detachment was 2 weeks. Intraocular pressures at baseline were 4.75, mean was 4.75 with plus minus 2.05 mmHg. Most of the patients were pseudophakic with total RD. Most patients had multiple small HSTs. 2 patients had large giant retinal tears, and 1 patient had a single macular hole. Now, the injection was performed at a median of 1 day prior to the vitreoretinal surgery, and in 1 patient it was 4 days before the vitreoretinal surgery because the patient was on platelet aggregator inhibitor and had to be stopped before taking up for surgery. Now, if we see the result, the intraocular pressure, it improved significantly from baseline to 2 hours post-injection, and then even further at the day of surgery. And the cumulative CD height, if we see, it reduced significantly from 15.8 to 5.5 on the day of surgery, and the mean also improved significantly. A few representative cases. In case 1, we can see there are massive choroidal mounts which are there, intraocular pressure of 4, massive mounts seen nasally as well as in inferior quadrant. And on the next day after injection, the intraocular pressure is improved. And on the bottom panel, we can see the choroidal detachments have almost flattened. Intraoperatively, we noted that all ports could be made safely into the vitreous cavity. After making a single port, we inspected the vitreous cavity for any residual CD mounts at the beginning of surgery. There were hardly any clinically evident CD mounts. And even after the fluid air exchange, we saw that there were no residual CD mounts at the end of surgery as well. At day 1, the intraocular pressures were normal and the oil fill was also normal. In a second case, we can see there is dense vitreous haze, which is there. Intraocular pressures are only 2, and there is a giant retinal tear, and in the superior as well as temporal longitudinal scan, we can see there is massive choroidal detachment mounds. 2 hours post injection, the intraocular pressures improved, and the day of injection, the next day, the intraocular pressures improved further. And we can see that in the superior quadrant, the CDF almost vanished, and temporal also it is almost flattened. And we can also see that the vitreous is significantly reduced, and the media clarity has improved. Now, in all these eyes, the IOP improved substantially, the CD reduced substantially. Vitreous haze also improved in all those eyes in which it was present. The surgery could be performed safely, and there was no clinically evident CD during the surgery. The oil fill was also adequate in all of these eyes. Now, we see the safety of these initially 8 eyes that were operated. There were no lenticular injury in the phakic patients. None of the patients had any post injection inflammation or infection. The fluid exchange or fluid air exchanges could be done normally. There was no unusual resistance. That means on even the day after injection on day 1, when we performed vitrectomy, we did not find any unusual resistance or helon. We could not observe the helon in the vitreous cavity. There was no unusual postoperative IOP rise as well. As of today, we have done around more than 25 cases over the last 1 year, and in all of these cases, we have consistently noted that the CD improves significantly and there is improvement in the intraocular pressure. Most of these patients we have managed using vitreoretinal surgery, but recently now we have started exploring other avenues also. Like we recently had performed scleral buckling in 2 of these eyes, in which the fellow eye had a poor outcome with vitreoretinal surgery, and one of the patient we even did a pneumatic retinopexy. Now, regarding the safety, one of the phakic patients had a lenticular injury, but it was just a minor breach of the capsule in the equatorial region, and it could be salvaged. And one patient, with an aim that we could achieve a higher intraocular pressure to allow scleral buckling, we injected twice in this patient at an interval of 3 days. And this patient on the contrary, had a high intraocular pressure that went up till 35 mmHg, and we had to give a short course of anti-glaucoma medication before taking up for surgery. Now, the choice of injection, we started with BSS, and then we came to 1% sodium hyaluronate that provided us a sustained tamponade, adequate tamponade with manageable removal. And we could even think of trying a 3% viscosity or a higher viscosity viscoelastic, but it might be difficult to remove it from the vitreous cavity. So that's why I've not yet tried this 3% injection. Now, in similar lines, if we see in 2011, Jung et al. Had published their results with pneumatic retinopexy for RRD with CD. And although they noted that the outcomes were dismal, only 33% of the eyes could achieve success. But they noted an important finding, which is corroborating with our study also, that by rapidly resolving the hypotony and choroidal detachments, it led to it facilitated the subsequent VR surgery. However, the concerns with injecting a gas instead of BSS or Helon would be that new breaks could easily form because of gas, and the breaks could enlarge, and the gas could migrate subretinally as well. The intraocular pressure rise could be unpredictable, and inflammation could also worsen, as we have often seen that gas-filled eyes, they have more inflammation and PVR setting in very quickly. To conclude, hypotony is an important factor that is often ignored in RRD with CD, and one tend to focus predominantly on the inflammation part. And by restoring the intraocular pressure early, we can interrupt the vicious cycle of hypotony, RD, and inflammation. And pivot is a safe and effective intervention that will transform this complex surgical scenario into a normal surgical scenario, so that you can either perform vitrectomy or maybe choose other surgical modalities such as scleral buckling or pneumatic also. Thank you.
Thank you so much, sir. That was a very nice presentation, and it's a good innovation because RD with CD is something which is very challenging to operate. And the last point which you brought about, that will break it to a normal surgical situation, is something very nice. I had one question that recently, just I think 2, 3 weeks ago, there was an article published in the British Journal of Ophthalmology by the Moorfields Group, where they've used HPMC injections to manage chronic hypotony. So have you tried HPMC or considered HPMC? Because typically we are told that HPMC produces inflammation, and even as cataract surgeons, when there's a red PCR, you say don't use HPMC, it will go
So
behind, cause
that
vitritis.
is the reason that I did not use HPMC. I've not yet tried it. and I don't want to try it since I've got some good results with this. So definitely I won't try a dispersive or even HPMC, because Helon is very inert, and we know that there's not much inflammation. Even if we leave it in the anterior chamber, there's hardly any inflammation after we leave the eye.
Definitely.
Although the pressures do rise, but yes, there's not much inflammation in the anterior chamber. So for the same reason, I have not tried that. But I'll go through the article that you have mentioned. And yes, this was also asked to me in one of the conference that this could be used as a solution for chronic hypotony, but I'm not sure, because in chronic hypotony it is the ciliary, maybe it is the cyclitic membranes which are there, and they need to be tackled rather than injecting Helon, which might momentarily improve the intraocular pressure, but will not take care of the underlying problem.
So this paper talks about repeat intravitreal HPMC injection. It's not just a single injection. After I think 3-4 weeks, they are repeating the injections. I've just gone through the abstract and
And they
briefly
have not
glanced through
noted
the
any
paper.
unusual inflammation or adverse.
They've written uveitis in the abstract, which was managed by topical and oral steroids, but a small proportion of cases.
I'll go
It's
through
like
it.
a pilot. It's just a pilot study from their side as well. If anyone from the panel or the audience has any questions, I think the point on gas was very nice. That was also a question I had in mind, but you covered it in the end, which answered the question.
Because I also went to the outcomes of pneumatic retinopexy, then I came across this important article, and it clearly they have mentioned that although the single surgery success rate with the pneumatic will be often poor in these eyes, but then it helps in facilitating the further surgery. So in one third of the eyes, their retina settled, but in the two third of the eyes, they could easily perform a vitrectomy. That's what they have mentioned. But then there is a fear that the subretinal gas, because often these eyes will have multiple breaks or large breaks, and that gas can go subretinal or can produce unpredictable
More
intraocular
points.
pressures. So that could also happen.
Very nice point, sir. Any more questions? I don't think there are any questions. Thank you so much for the presentation, and thank you everyone for joining in. We had a nice learning session. All the speakers, Ambya sir, Jayant sir, Devesh sir, Komal ma'am, I think Dr. RN and Professor Jemmy have left. Thank you so much for joining, and in your free time after working hours on a weekday when we have to get back to work tomorrow. It was definitely worth it, and we got to learn a lot from all of you. Thank you so much.
Thanks, Arjun.
Thank
Thank
you.
you, Arjun. Thank you.